So from today we will start about the hematinics. So within the hematinics we will discuss about the drugs that are needed mainly management of anemia first. There are different types of the anemia we will discuss. There are most commonly iron deficiency anemia. There are vitamin B12 and folic acid deficiency that may lead to megaloblastic anemia. There are anemia from chronic diseases. There may be some erythropoietin deficiency, etc. After that, we will discuss about the coagulant drug, anticoagulant drug, and different other drugs that are utilized in blood coagulation or thrombolysis, etc. For example, there are some thrombolytic drug, antithrombolytic drug, antiplatelet drug. We will all discuss plasma expander. We will all discuss under this hematopoietic system or hematinics chapter. So first, we will discuss about the most important is the anemia. You know this anemia, particularly iron deficiency anemia, is very common throughout the world. Approximately 1/4 of our population are suffering from anemia, mostly iron deficiency anemia, and that is prevalent both in case of the developed as well as the underdeveloped countries, and more in the underdeveloped countries. And females as well as the children, they are more prone to iron deficiency anemia. Now what happens? Iron is a very essential element of our body. What happens? Iron is present in different foods, different vegetables it is present, different non-veg foods it is present, but mostly iron is present as a complex with phytates, polyphenols, etc. that are difficult to absorb in our body. So there are different types of the enzymes that ultimately help iron absorption. But it also happens that if there is more free iron, that is also toxic to our body. So ultimately it is a two-edged sword where we have to balance the iron absorption and ultimately iron requirement according to the iron requirement of the body. Now first let's discuss about what are hematinics. So hematinics are basically agents, that is these are the agents or drugs which are required for the formation of the blood. So physiologically it is present, these agents hematinics that are needed for the formation of the blood and that are also used for the treatment of anemia. The most common hematinics are the iron, folic acid, vitamin B12 and also there is erythropoietin. Now let's start about the anemia. What I am talking, that anemia is basically defined as a below normal plasma hemoglobin level concentration that may result from myriad causes. There are different causes that may lead to anemia. So there may be decreased number of circulating red blood cells most commonly, or an abnormally low total hemoglobin content per unit of the blood volume. So you know the hemoglobin content, if it is less than 13 gram per deciliter, in case of the males usually it is known as the anemia. Similarly, in case of the females, if it is less than 12 gram per deciliter, it can be called as anemia. And usually we need treatment if the hemoglobin level is less than 10 gram per deciliter. So if it is less than 10 gram per deciliter, we have to treat the disease. And we can say that the patient having critical anemia if it is less than 7 gram per deciliter. Particularly when there is very diminished hemoglobin level and the patient is in the hypoxia or the patient needs urgent replenishment of iron store, we will need blood transfusion. Apart from this, we have to supply the iron preparation, iron by means of different types of the preparations in case of the iron deficiency anemia. The preparations most commonly are the oral iron. Apart from this, there are parenteral iron preparations are there which are also required in selected cases. So anemia can be caused by the chronic blood loss. Chronic blood loss may be, for example, it may be from some bleeding peptic ulcer, or it may be from some bleeding hemorrhoids, that is piles. That may be some bone marrow abnormalities, that is bone marrow may be depressed. So ultimately that may also lead to less hemoglobin, less red blood cells. Increased hemolysis. So the red blood cell is formed but it is increasingly being destroyed by different types of the causes. There may be some infections, malignancy, some endocrine problems, renal failure, chronic kidney disease and a number of other disease states that may lead to anemia. So nutritional anemia is called when there is most commonly some iron deficiency anemia or vitamin B12 deficiency anemia or folic acid deficiency anemia that ultimately hampers the normal erythropoiesis, normal process of the RBC development. Individuals with anemia that has a genetic basis, that may be sickle cell disease. So there may be some anemia that may happen due to some genetic problems like sickle cell anemia. That may need pharmacological treatment by some other ways. For example, we need hydroxyurea in case of the sickle cell anemia. Anemia can be temporarily collected by transfusion of whole blood, what I have already talked. So you can see how the blood cells, red blood cells are generated. So when there is problem of the vitamin B12 deficiency or folate deficiency or iron deficiency, that will be inhibition of the DNA synthesis that ultimately helps cell multiplication or inhibition of the hemoglobin synthesis. Both this can happen. Some patients may have both iron deficiency as well as the vitamin B12 deficiency also. So when there is iron deficiency anemia, that leads to small hemoglobin poor erythrocytes. Usually iron deficiency anemia is associated with microcytic hypochromic anemia. This will be discussed in your pathology class. Okay, what is microcytosis, what is hypochromia? And usually in vitamin B12 or folic acid deficiency, there occurs megaloblastosis, and that leads to macrocytic or megaloblastic anemia. Okay. So anemia again, basically this is a condition where the balance between the production and the destruction of the RBC is disturbed. So there may be some decreased production or there may be some increased destruction. Both may happen in case of the anemia. So general sign symptoms are fatigue, general fatigue, the patient feel tired, there may be rapid heartbeat, there may be tachycardia, shortness of the breath, dyspnea may happen, pale skin, you will see the pallor, dizziness, insomnia, all this happens due to the anemia. So anemia may be blood loss, chronic blood loss most commonly, I have given example, or some acute blood loss, that is there may be some road traffic accident. Impaired cell formation happens due to some iron, vitamin B12 or folic acid deficiency, which is caused due to the deficiency of these essential factors, or bone marrow depression due to some disease like some aplastic anemia or due to erythropoietin deficiency, there may be bone marrow depression, so the erythropoiesis will not happen, or there may be some increased cell destruction, this is known as the hemolytic anemia, that may also happen. So there are number of the drugs are also there. These drugs have toxic effect on the red blood cells. So when these drugs are given, there may also be anemia may develop, most commonly different types of the chemotherapeutic drugs. That may also leads to anemia. So basically in broad heading, we can say anemia may be caused by these three types of the causes. Now coming to the iron, what I am talking that iron is ubiquitous in the environment, but it is difficult to absorb. Okay. So the body must protect itself from the free iron. So when the iron is present in plenty or when the iron is more absorbed, that is not required for our body, that leads to more free iron in the plasma, that is also toxic for our body. The major role of the iron in case of the mammals is to carry oxygen as part of the hemoglobin. The most important thing, carry of the oxygen in different cells of the body. So if there is anemia, there is hamper of the oxygen, so ultimately cells may die. That is the problem. So iron deficiency is one of the most prevalent form of the malnutrition. Globally, 40 to 50% of the anemia is attributable to iron deficiency anemia. Iron deficiency anemia is the most common anemia. You will deal in the OPD also, you will see plenty of the patients, plenty of the cases that are present with iron deficiency anemia. Some of these patients are directly due to the nutritional deficiency. Some of these patients may have some other problems that also leads to iron deficiency anemia. So how the iron is distributed in our body? So total body iron in the adult is approximately 2.5 to 5 gram. It is more in men in comparison to the women. It is distributed mostly in the hemoglobin. 60% of the iron is present in the hemoglobin. Apart from this, approximately 25% present as iron storage form in our body in the form of the ferritin and hemosiderin. So storage form is required when there is iron deficiency. Iron is ultimately extracted from the storage form into the plasma so that it can go in the plasma to different cells. Myoglobin contains approximately 3% of total iron, and parenchymal iron, that is within the cells, within the parenchyma of the cells present small amount of the iron, approximately 6%. You have already know about the structure of the hemoglobin, you have read in the physiology. So it is basically a protoporphyrin. Each molecule of hemoglobin basically contains 4 iron containing heme residues. So heme residues is the core part of the hemoglobin that contains the iron. That amount to approximately 1.1 milligram, approximately 20 micromole of iron per milliliter of the red blood cells, and it has approximately 0.33% iron, each hemoglobin. So hemoglobin is the principal part where the iron content in our body is present. This is the daily requirement of iron. Every day, what is the amount? So to make up the average daily loss, iron requirements in case of the adult male approximately 0.5 to 1 milligram. It is somewhat more in case of the females, 1 to 2 milligram. In infants 60 microgram per kg, children 25 microgram per kg, and in pregnancy much larger amount of the iron is needed, approximately 3 to 5 milligram is needed. That's why usually in pregnancy iron replenishment is done irrespective of the presence of anemia or not. So this is the dietary sources of the iron. Some foods are more rich in the iron and some are less. This liver, different animal liver, egg yolk, oyster, dry beans, dry foods, wheat germ, yeast, they contains large amount of the iron. Medium iron content is the meat, chicken, fish, spinach, banana and apple, and very poor iron content is the milk and its product and some root vegetables like potato. So they contain very less amount of the iron. So when we will ask the patient to increase their iron content in case of the iron deficiency anemia, we have to counsel the patients about taking this type of the foods more, okay, so that there will be more iron will be available to their body. Now coming to the iron absorption, what I am talking now this iron absorption is the principal way by which our body regulates what amount of the iron will be available to different cells or not. In different other elements, the elimination or excretion and metabolism mainly plays a part, but in case of the iron, absorption of the iron mainly plays a part. How the body content of the iron will be, how the iron will be absorbed, what will be the requirement of the iron, and accordingly the balance of the iron is maintained. All these are maintained by means of the iron absorption. So average daily diet of ours usually contains 10 to 20 milligram of iron irrespective of what we are taking. Now its absorption occurs all over the intestine, but most of the iron absorption happens in case of the duodenum and early jejunum. Dietary iron is present mainly in two forms. One is the heme iron, another is the inorganic iron. Heme iron is present in different types of the foods also. Heme iron is easier to absorb in comparison to the inorganic iron. The major part of the dietary iron is the inorganic. So dietary iron mainly in case of the vegetables, the inorganic iron is present that is difficult to absorb in our body. That because it is present in the ferric form. When the iron is present in the ferrous form, that is easier to absorb in our body. Ferric form, it has to be converted to the ferrous form before its absorption. Two separate iron transporters are there that mainly helps in the iron absorption. One is the divalent metal transporter 1, which is present at the luminal membrane of the enterocytes, that is the intestinal cells. Another is the Ferroportin, which is present in the basolateral side. So this is how the iron absorption happens. So you can see this is the dietary iron, the blue ones. Dietary iron, again I am telling that it is present in plenty of the foods, but mostly dietary iron is present in different types of the vegetables in inorganic iron form. These are in the ferric form. For absorption in our body, it has to be converted to the ferrous form. Apart from this, there are heme iron and some iron which are already in the ferrous form that are easier to absorb. So you can see ferric iron have to be converted to the ferrous form by means of the acids and the reducing agents. Usually cytochrome B related some ferric oxidase is present that ultimately converts the ferric iron to ferrous iron. So cytochrome B related ferric oxidase system mainly converts the ferric iron to ferrous iron. On the other hand, this heme iron usually does not need any carriers for entry within the enterocytes. you can see there is no carrier that can enter, or ferrous iron that can enter easily within the enterocytes. But this ferric iron have to be converted to the ferrous iron by cytochrome B systems, and then it has to be entered within the enterocytes by means of a transporter known as the DMT1 or divalent metal transporter 1. Okay. Divalent metal transporter 1 is present in the luminal side of the enterocytes, that is the intestinal cells, luminal side. So when we are taking the foods that comes in the gastrointestinal system, within the lumen side there are cells that contains the divalent metal transporter 1, and that also contains the cytochrome B related ferric oxidase system. So heme iron, other ferric iron that are converted to ferrous iron that are absorbed to the enterocytes by means of the divalent metal transporter 1 within the mucosal cells or enterocytes, intestinal cells. Within the intestinal cells, some part of it is ultimately converted to the ferric form, and ultimately it is stored as ferritin. So some part of the iron is stored as ferritin within the enterocytes or intestinal cells, and some part ultimately comes within the plasma by means of another transporter, which is the ferroportin, usually ferroportin 1. So it is clear, some part it is stored within the enterocytes in the form of the ferritin, and this ferritin form is for storage within the ferritin form. Again the ferrous iron has to be converted to the ferric form. Okay, and this by means of the ferroportin, some part of the iron goes to the plasma, and here there is another protein known as the hepcidin, Hepcidin. Hepcidin is the key regulator of how much amount of the iron will come to the plasma and how much amount of the iron will be stored within the enterocytes, hepcidin. So when there is iron deficiency in our body, usually the hepcidin expression will be less. What happens? This hepcidin ultimately attaches with the ferroportin and decreases the transfer or export of the iron from the luminal cells to the plasma. So it is clear, hepcidin is a key regulator of the iron balance that is present, that is usually synthesized from the liver. This is present in the plasma, and that also comes within the enterocytes. This hepcidin regulates. How it regulates? Hepcidin attaches with this ferroportin. This ferroportin is responsible for the export of the iron from the luminal cells to the plasma. When this hepcidin attaches with this ferroportin, there will be less iron will be extracted out to the plasma. So when there will be more hepcidin expression, there will be less iron in our body, less iron will be in the plasma. Okay, and when there is iron deficiency, the hepcidin expression will be decreased. When the hepcidin expression will be decreased, there will be less hepcidin to bind with the ferroportin. So there will be more ferroportin will be available for export of this iron from these intestinal cells to the plasma. So it is clear. So there is another protein that is known as the hepcidin. Hepcidin mainly converts this ferrous form that comes in the plasma to the ferric form. Because this ferric form is again needed to bind with another transporter protein known as the transferrin, for transfer of this iron to different cells of our body as well as the reticuloendothelial cells. So until this is clear. So ultimately iron comes in the plasma. So from the plasma, the iron have to be transported to different cells and also reticuloendothelial cells where the RBC production happens. Now this transfer of the iron usually happens in combination with another protein. This is known as the transferrin. For binding of this ferrous protein to transferrin, it has again to be converted to the ferric iron, and this ferrous to ferric iron is conversion in the plasma before it is binding to the transferrin happens by means of another protein that is known as the hepcidin, Hepcidin, hepcidin. So here the main regulator is the hepcidin, and then the hepcidin converts the ferric to ferrous iron. that ferrous iron binds with this transferrin. That transferrin ultimately goes to different cells like reticuloendothelial cells and also within the bone marrow erythrocyte precursor, so that the RBC can be generated. Within these reticuloendothelial cells, again some part of this iron is stored, and this storage is the principal form of the storage. Again this storage happens in the form of the ferritin and in some part hemosiderin. So this reticuloendothelial cell means liver, spleen. So liver, spleen, etc. mainly contains the maximum part of the storage of the iron, and some part of the iron goes to the different cells and also to the erythrocyte precursors where the RBC development happens, heme inclusion happens, and ultimately RBC is developed. So it is clear. So when there is iron deficiency, what happens? When there is iron deficiency, there will be more absorption in every other side. So when there is iron deficiency, here the ferritin, some part of the small part of the ferritin that is stored within the enterocytes is also less. Hepcidin expression will be less, so that more iron will be available to the plasma. More iron binding happens to the transferrin because this transferrin is also upregulated, and this transferrin bound iron again comes to the different cells. From the reticuloendothelial cell storage form also less storage of the iron in the form of the ferritin will happen. Some part of the storage form again will be extracted out when there is iron deficiency from these reticuloendothelial cells to the plasma, and ultimately all this iron will be more available to the erythrocyte precursor cells, so that the RBC generation will be more. This happens when there is iron deficiency. Again, if there is no iron deficiency in our body, if it is normal, so after a certain period these enterocyte cells will be shed, and ultimately it comes out through the stool of us in the gastrointestinal tract. So ultimately this can be called as a ferritin curtain. It acts as a curtain so that there will be no iron toxicity, so that there will be no more iron absorption happens, that ultimately will not required by the body. So there a balance is there so that more absorption will not happen, because more absorption of the iron leads to more toxicity. Free iron is very much toxic to the body, because that may lead to the different superoxide iron formation. Free radical damage may happen to the cells, that's why. Okay. So this way the iron absorption happens. So there are some factors that affect the iron absorption. Some things facilitates iron absorption, like acid, ascorbic acid, amino acid that contains sulfhydryl radical, and meat. So usually when a patient are very much iron deficient state, we can tell that the patient can take the iron with some fruit juice or some vitamin C tablets, because vitamin C or ascorbic acid facilitates more iron absorption. Again, there are some things that impedes the iron absorption. For example, phosphate, phytates, these are abundantly present in the vegetables. Ultimately, when these are taken with foods, the iron will be less absorbed when this phosphate binded, phytate binded, etc. Some alkalis like antacids as well as the different proton pump inhibitor also impedes the iron absorption. Tetracycline is a drug. Other foods in the stomach, if there is food in the stomach, that impedes the iron absorption, but if the patient takes iron in the empty stomach, that will be more iron absorption. That's why you can say, you can see that when iron is taken, usually the patient is asked not to take the antacids or some proton pump inhibitor that may impede the iron absorption, because the patient is iron deficiency anemia. We want to correct the anemia, so we need iron tablets. When the iron tablet is given, patient is also asked not to take antacids within, for example, 1 hour or 2 hours, not to take proton pump inhibitor, because that decreases the pH of the stomach. If the pH of the stomach is decreased, ultimately ferric form will not be converted to the ferrous form. Less ferric form will be converted to the ferrous form. So ultimately all this impedes the iron absorption. So already we have discussed again what is mucosal block. So mucosal block is basically a mechanism to prevent entry of excess iron in the body. What I am talking, ferritin curtain. Within the enterocyte, some form is stored as ferritin, and that ultimately acts as a mucosal block. So this form either transported to the plasma or oxidized to ferric form and complexed with apoferritin to form the ferritin. This one. This is converted to the ferric form and ultimately it binds with apoferritin to forms the ferritin. This ferritin generally remains stored in the mucosal cells and is lost when they are shed. Lifespan is 2 to 4 days. This is called the ferritin curtain. If we do not need more iron, it will be shed. We are taking food every day, so ultimately this storage within the enterocytes usually spans approximately 2 to 4 days. After that it will be shed, again the newer storage will occur. This is known as the ferritin curtain. The iron status of the body and the erythropoietic activity govern the balance between these two processes. Already I have said that the iron status, what will be the iron status? If the body have iron deficient state or not, and also erythropoietic activity, whether the erythropoiesis is occurring as it is needed or the erythropoiesis is very slow. These two ultimately determines how amount of the iron will come. What the food may be the same, but the absorption of the iron from the intestinal cells to the plasma, from the plasma to the reticuloendothelial cells and the different erythrocyte precursors will be determined and governed by this. When body iron is low or erythropoiesis is occurring briskly, ferritin is either not formed, you can see, or dissociate soon. So the ferritin is the storage form. If we need the urgent iron, the storage form will be very less. The released iron is transported to the blood. So free iron is highly toxic, what I have talked, and on entering plasma, it is immediately converted to the ferric form and complexed with the glycoprotein transferrin. So that's why transferrin saturation is an indicator by which we can see that whether there is iron deficiency is present in our body or not. And there is the ferritin. What will be the serum ferritin? That is also ultimately dictates, we can say from this, that what will be the iron content in our body. So iron circulates in plasma bound to transferrin, usually 2 ferric residues per molecule, and the total plasma content of the iron is 3 milligram. That recycle 10 times every day and turnover of iron is 30 milligram per day. So ultimately recycling happens and again it will continue. Iron is transported inside erythropoietic and other cells through the attachment of the transferrin to specific membrane bound transferrin receptors. So ultimately transferrin attaches with the transferrin receptor and then they are engulfed within the cells or reticuloendothelial cells by means of the receptor mediated endocytosis. Okay. Iron dissociates from the complex at the acidic pH of the intracellular vesicles. Within the intracellular vesicles it will be dissociated. The released iron is utilized for hemoglobin synthesis. The last part, hemoglobin synthesis, it will be needed, while transferrin and transferrin receptor are returned to the cell surface to carry fresh load. So ultimately transferrin attaches with the transferrin receptor, it will be engulfed, endocytosed, and then within the acidic pH the iron is released, helps in the heme formation, and this transferrin receptor again will be upregulated to the surface for the fresh load of the iron. In iron deficiency and hemolytic states, iron deficiency is there or hemolytic states. Hemolytic means iron RBC is formed but it will be destroyed. When bricks erythropoiesis is occurring, so more and more RBC formation is occurring, erythropoietic cells express more transferrin receptor, selectively more efficient in trapping iron. So ultimately all these are proteins and these proteins are ultimately regulated by the body requirement. So when the requirement will be more, there will be more expression, more transcription of these proteins, more transferrin receptors will be available. The hepcidin receptor will be less expressed like this. So hepcidin, remember, will be the central regulator how much amount of the iron will be transported in the plasma from the enterocytes. And the transferrin is the protein that leads to the transfer of the iron to different cells and erythrocyte precursors. Iron is stored in the reticuloendothelial cells. Reticuloendothelial cells means liver, spleen, bone marrow, hepatocytes and myocytes in the form of ferritin and hemosiderin. Ferritin at full saturation can hold 30% iron by weight. So ferritin saturation can also be decreased when there is some problems in the iron. Parenchymal iron occurs as prosthetic groups and ultimately that is present in different types of the enzymes that are used in respiratory chain. For example, cytochromes, peroxidase, catalase, xanthine oxidase and different mitochondrial enzymes. Mitochondrial respiratory chains, it is present. Iron is tenaciously conserved by the body. Remember, whatever iron it is present, whatever it is absorbed, most of part of it is ultimately stored within our body in the enterocytes, in different reticuloendothelial cells, mostly in the form of the ferritin, some part in the form of the hemosiderin. That's why tenaciously conserved. Daily excretion in adult males is only 0.5 to 1 milligram, mainly as exfoliated gastrointestinal mucosal cells, some RBC and in bile. This is how it is excretion happens. In menstruating women, monthly menstrual loss may be more, 0.5 to 1 milligram per day. Okay, that's why in case of the females, the iron requirement will be more, and also iron deficiency anemia is very common in case of the females. The same thing, so it is clear how the iron absorption happens and what is the role of the different proteins. This is very important. Now coming to the preparations and doses. Now iron deficiency anemia is ultimately diagnosed and we have to treat. Treatment is done by means of the iron preparations. Most common iron preparations that is utilized is the oral iron preparations, usually in the form of the tablet, very less often in the form of the syrups. So oral tablet, usually ferrous sulfate 100 to 200 milligram per day is given, usually in the divided doses. Iron liquid preparation is usually given in case of the children when there is iron deficiency. Tablet is the choice of preparation for the adults. So you can see these are the different preparation, ferrous sulfate more common, or ferrous fumarate, ferrous succinate, ferrous gluconate, etc. There are different free iron content within this, and accordingly we have to determine how much amount of the iron tablet have to be given. Carbonyl iron is the newer one, which is a high purity metallic iron in very fine powder form. Okay. So what happens, usually at 200 milligram of elemental iron, infants and children 3 to 5 milligram per kg, given daily 2 or 3 divided doses, that produces the maximum hematopoietic response. Now what happens when the iron tablet is given, there are the most common problem is the gastrointestinal problems. Gastrointestinal tolerance to the iron is very problem in many patients. So some patients may complain of nausea, some patients complain of vomiting, some complain of diarrhea, and some also complain of constipation. And different gastrointestinal problems, bloating, metallic taste, all these can lead to non-adherence to the treatment. That is, patient will not take the medication as it should be taken. So ultimately the anemia will not be corrected, and the patient can tell that I am taking the tablet, but the patient is taking the tablet very haphazardly and their anemia will not be corrected. So the different researches have been done, and it has been seen that if we are giving the iron tablet in alternative day, that also gives an equal benefit. So those patients who cannot tolerate the oral iron, we can try with the alternate day therapy. Next is, already we have seen that iron absorption is more when it is given in case of the empty stomach, and iron absorption is less when it is given in the full stomach. So it should be that we should give the iron tablet in the empty stomach before meal or in between meals, so that the absorption will be more. But again, when the iron is given in the empty stomach, these gastrointestinal problems will be more. In some patients, the patients will not tolerate. So in some patients we have to compromise, and we have to give the iron tablets after meal also. In spite of after meal, the iron tablets will be absorbed less, but the patient can tolerate it better. So these are the tailoring of the treatment that will be needed. So you have to understand that iron absorption is more in case of the empty stomach. Primarily we have to give the iron tablets in the empty stomach, that is in between meals or before meals. But some patients cannot tolerate these iron tablets because of the gastrointestinal problems. That's why we can give it after meals, or we can give it alternative day therapy, and in different trials it has been seen that ultimately that leads to better adherence of these patients to the iron therapy. Okay. So gastric irritation and constipation are related to the total quantity of the elemental iron administered. Already we have discussed absorption is much better and how the therapy is usually given. Now coming to the parental iron. So in some patients, the patient cannot tolerate the oral iron whatsoever. The patient cannot tolerate. And in some of the cases, we need the urgent replenishment of the iron. That will not happen with oral iron therapy. So we have to give the parenteral iron. And some anemia with chronic disease, where we are expecting bricks erythropoiesis, like when we are giving erythropoietin in case of the anemia in chronic kidney disease, we have to replenish by means of the parenteral iron therapy, that is injectable iron therapy. So indication is when oral iron is not tolerated, bowel upset is too much, even if it is given after meals, it is given alternative day therapy, the patient cannot tolerate. Failure to absorb oral iron, that is if there is some disease where the absorption will not happen from the gastrointestinal tract, like there may be some malabsorption syndrome, like celiac disease, tropical sprue, where there is problems in the intestinal cells and malabsorption happens. And another is the inflammatory bowel disease. Inflammatory bowel disease means ulcerative colitis or Crohn's disease, where the inflammation in the bowel happens and the absorption of different foods and also iron becomes hampered very much. So here, even if we are giving the oral iron, even if the patient tolerates, the iron absorption will not happen. So here we have to give the parenteral iron therapy. Next, coming to the chronic inflammation like rheumatoid arthritis, that decreases iron absorption and the rate at which iron can be utilized. So we have to increase the rate. Non-compliance to oral iron, that is the patient will not take the oral iron. In presence of the severe deficiency with chronic bleeding and along with erythropoietin, I have already told that erythropoietin we will discuss later, it is given in case of the anemia due to chronic kidney disease. When we are giving the erythropoietin, there will be bricks erythropoiesis, and to meet up this we have to need more iron and we have to give the parenteral iron therapy. So these are the indications. So when you will be asked that when the parenteral iron therapy is given, so these are the indications where the parenteral iron therapy is indicated, in oral iron is not given. So there are different types of the preparations of the parenteral iron. Some are older preparations and some are newer preparations. The problem of the older preparations are the anaphylaxis or different severe allergic reactions. That's why the newer preparations are more commonly used nowadays. Iron dextran is a high molecular weight colloidal solution, contains 50 milligram elemental iron per milliliter. That is the only preparation that can be injected both intramuscularly as well as the intravenously. Anaphylactic reactions are more common. This is the older preparation. Previously iron dextran is given. Iron sorbitol citric acid, this is a low molecular weight complex. It can be injected only intramuscularly from where absorption occurs directly into the circulation and not through lymphatics. Again, anaphylaxis can happen. So iron dextran, iron sorbitol citric acid. This is somewhat newer, ferrous sucrose. Ferrous sucrose is a parenteral iron preparation which is a high molecular weight complex of the iron hydroxide with sucrose. So basically this is a chiral molecule where the iron hydroxide is attaches with a sucrose molecule and it becomes a high molecular weight. It is safer than the oral iron dextran or iron sorbitol citric acid. Usually the dose of 100 milligram injected intravenously taking 5 minutes, that is slow injection is giving once daily weekly till the calculated dose is achieved. So we have to calculate the dose, how much amount of the dose is needed by means of this iron requirement calculation. There are newer calculations, several different types of the calculations are there. For example, iron requirement in milligram is the 4.4 into body weight in kg into hemoglobin deficit in gram per deciliter. For example, the hemoglobin we need approximately 13, the patient of hemoglobin is approximately 8. So ultimately the hemoglobin deficit is 5 gram per deciliter. Body weight for example is 70. So 5 into 70 into 4.4. So this will be the milligram of iron requirement. Then we have to divide this in different days. For example, we have to give the 100 milligram one day weekly. In the next week we have to give another 100 milligram like this, and this total dose, total iron requirement and ultimately replenish to the patient in several weeks. So oral iron should not be given concurrently or till 5 days after last injection. Usually parenteral iron is done, full replenishment is covered, and then we have to start with the oral iron because so that there will be no drop of the hemoglobin immediately. Okay. So the incidence of the hypersensitivity reaction is low with the ferrous sucrose. This ferric carboxymaltose is the newer ones are very commonly used nowadays, ferric carboxymaltose, and newest one is the iron isomaltoside. So ferric carboxymaltose, iron isomaltoside, these two are the newer oral iron preparations where the anaphylaxis chance is very less. Another is it can be given in the one shot also. In the previous ones, usually the patient have to get admitted in the hospital. Usually it is to be given with some infusion, that is with the saline it has to be given, but these newer preparations can be given with the infusion, or it can be given by a direct shot, direct injection it can be given. So here ferric carboxymaltose is basically a ferric hydroxide core, it's stabilized by a carbohydrate cell. So within the cell, in the outside there is carbohydrate, in the inside there is ferric hydroxide core. It is rapidly taken up by the reticuloendothelial cells when it is injected in the bone marrow, liver and spleen. Iron is released and delivered to target cells. Usually it is administered daily 100 milligram IV injection. So direct 100 milligram IV injection can be given, or it can be diluted with the 100 ml of a solution 1000 milligram, and again it can be infused IV taking 15 minutes or more if the patient is already admitted in the hospital, or otherwise it can be given in the home also by means of the qualified personnel. Incidence of the acute reaction is very low, pain at injection site and rashes can occur. So headache, nausea, abdominal pain usually is generally mild. So ferric carboxymaltose can be given as an injection shot 100 milligram, or it can be given with infusion. The chance of the anaphylaxis is very less. The newest one is the iron isomaltoside. It is marketed in India 2016. Here also iron bound tightly with a matrix of the isomaltoside 1000. Again, these are all like of the liposomes. You have read about the liposomes. You can say these are like liposomal preparations where the outer core is separate with some carbohydrate core and inside there is ferrous is present. Oligosaccharide with mean molecular weight 1000. Isomaltoside is the matrix. After IV injection, it is taken up by the reticuloendothelial cells. Similarly, the tight binding of the matrix releases very little labile iron responsible for the toxicity. So in the previous ones, the toxicity means the anaphylaxis mainly happens to the free iron. When we are injecting the iron, there will be more free iron will be available with the ferrous sucrose or the previous ones. But these newer preparations, when it is injected, the after injection that will be stored within the body, and from the matrix very slowly the iron absorption will happen, so that the total iron content will not be very rich, so that there will be labile iron toxicity and the iron deficiency will also be corrected. That is why the anaphylaxis chance is very less. It permits administration of the high single dose of the 1 to 2 gram IV. Since the anaphylaxis chance toxicity is very less, so we can administer very high dose at a time, because we need immediate correction of the iron. In the previous one you can see that only 100 milligram can be given. So when the requirement is high, we need several weeks treatment so that the iron replenishment will happen. But when the newer ones will be given, we can give very high doses with little adverse effect. Okay. So you can see high single dose of 1 to 2 gram, previously 100 milligram is given, here 1 to 2 gram IV can be given once at a time, and it will be released very slowly in our body, so that there will be very less toxicity. Low immunogenic potential, convenient and cost saving due to single short period IV infusion. But the only problem is the cost now with the iron isomaltoside and ferric carboxymaltose. So parenteral iron therapy is very important. You have to read what are the indications of the parenteral iron therapy, what are the parenteral iron preparations. So these are the parenteral iron preparations. Previously iron dextran, iron sorbitol citric acid. Main problem is the labile iron toxicity that leads to anaphylaxis. The ferrous sucrose is the newer one, and the newest one is the ferric carboxymaltose and the iron isomaltoside 1000. So uses of the iron deficiency anemia already we have seen. This is the main treatment, iron, for the iron deficiency anemia. Apart from this, in case of the megaloblastic anemia also, when there is erythropoiesis happening after correction with the vitamin B12 or folic acid, we need the iron, because erythropoiesis needs the iron, because it needs the heme formation, or it can be used as an astringent also, in very less use as throat pain. Adverse effect already I have discussed. Main adverse effect is the gastrointestinal. So there may be nausea, epigastric pain, diarrhea or constipation, both can happen. Staining of the teeth, metallic taste. So tolerance of the iron can be achieved by starting with a very small dose, usually after food, usually in the alternative day therapy, etc., and ultimately gradually escalating the dose and reaching to the optimal dose. And the local, when we are injecting, there may be some pain at site of the intramuscular injection, pigmentation of skin, sterile abscess can happen. Fever, headache, joint pain, flushing, palpitation, chest pain, dyspnea, all this can happen, particularly with the older preparations. With the newer preparations, newer parenteral iron preparations, these adverse effects will be less. Okay. Acute iron poisoning, when we are giving too much of the iron or the patient have taken more iron tablets at a time, so there may be some iron poisoning. Because an excess of the iron is deposited in the heart, liver, pancreas and other organs, leading to the organ failure and death. It occurs mostly in the infants and children, very rare in adults. Manifestation is by vomiting, abdominal pain, hematemesis, diarrhea, lethargy, cyanosis, dehydration, acidosis, convulsion, all can happen. So acute iron poisoning can happen. Usually the treatment is to prevent, so that there will be no further absorption of iron from the gut. To induce the vomiting or perform the gastric lavage, so that the iron already present in the system will be removed. To bind and remove iron already absorbed, and this removal is usually done by some iron chelating agent. In the end, you will read about the different other chelating agents also. One of the chelating agent is the desferrioxamine. Desferrioxamine is the iron chelating agent that is used in the acute iron poisoning, and the second use that is most commonly used in case of the thalassemia. So when we are treating the thalassemia, you know that multiple or repeated blood transfusion is done. When the repeated blood transfusion is done, there will be more iron overloading. So iron overloading, when it will be done, the iron will be deposited in different organs, and that ultimately leads to iron toxicity. So desferrioxamine, and the oral formulation of this is known as the deferriprone. These are mainly used to decrease the iron toxicity in case of the thalassemia patients, who usually needs multiple blood transfusion, and also in acute iron poisoning patients. So this is clear. Apart from this, fluid and electrolyte balance should be maintained, respiration, blood pressure support, diazepam, IV, etc. is to be given. So this is the acute iron poisoning. So apart from iron, there are some adjuvant hematinics like copper, pyridoxine and riboflavin. Some deficiency may happen, details is not required, but remember this replenishment of this can also be needed in some of the cases. Next, starting with the maturation factors. So iron is mainly needed for the erythropoiesis, and now maturation factors is called to the two elements. One is the vitamin B12, another is the folic acid. So vitamin B12 and folic acid deficiency, basically when the deficiency happens, there is problems in the maturation of the RBC. So that leads to megaloblastic anemia, that is characterized by the presence of the large red cells precursors in the bone marrow. So red cells become large because there will be more cytoplasm, large and short-lived progeny in the peripheral blood, but the DNA synthesis defect will be there. So the nucleus and the DNA synthesis is defect is there, but the cytoplasm will be more, so there will be megaloblastosis, and these megaloblastic RBCs are very poor in transferring the oxygen in different cells. So ultimately that also leads to anemia. So here the heme content may be normal, but since the iron, since the RBCs are very short-lived, the RBCs are very inefficient in transferring the oxygen in different cells, that also leads to anemia. This is known as the megaloblastic anemia. That's why this vitamin B12 and folic acid are known as the maturation factors, because they are needed for the maturation of the RBCs. So apart from the hematopoietic cells, other rapidly proliferating tissues are also suffers from this vitamin B12 and folic acid deficiency. Now first starting with the vitamin B12. So vitamin B12 mainly present in the two forms. One is the cyanocobalamin, another is the hydroxycobalamin. So cobalamin means cobalt containing cobalt, that mainly contains the cobalt. So this vitamin contains cobalt, complex cobalt containing compounds that is present in the diet, and these all are known as the vitamin B12, cyanocobalamin and hydroxycobalamin. What are the dietary sources? Usually the liver, kidney, sea fish, egg yolk, meat, cheese, they are the main vitamin B12 that are mainly present. So different types of the animal foods are mainly the content of the vitamin B12. Vegetable source is very less, only the legumes is only vegetable source, because in their root nodules there are some microorganisms that harbors within the root nodules of the legumes that mainly synthesize the vitamin B12. That's why vitamin B12 is very less in case of the vegetables, different vegetables, only in case of the legumes it is present. Now vitamin B12 is synthesized by the colonic microflora. Within the colon of ours there are microflora. From these foods the vitamin B12 is synthesized, but this is not available for absorption in our body. So in spite this vitamin B12 is metabolized in our body by colonic microbacteria, it is not absorbed. What will be absorbed? The vitamin B12 that is present in the animal food, that is directly absorbed within our body. The commercial source is the Streptomyces griseus. Daily requirement is approximately 1 to 3 microgram, while in case of the pregnancy and lactation it is increased 3 to 5 microgram. So you can see this is the vitamin B12 containing foods. So fish, you can say poultry, nuts, eggs, meat, cheese, oyster, clam, milk and soya milk also contains different types of the vitamin B12. So in the next class we will discuss about how the vitamin B12 metabolism happens, what will be the vitamin B12 folic acid deficiency, how it will be treated, and then we will go to the erythropoietin and different types of the plasma expanders. So today we have discussed extensively on the iron deficiency anemia and iron. These are very important. How the iron absorption happens, what are the role of the different proteins and transporters, how the iron tablets is given, what will be the problems if it is given in the empty stomach, etc. These are important questions. And next is the parental iron preparations, everything about the parental iron preparations. And within the vitamin B12 we will discuss about later, but mostly remember vitamin B12 mainly available in our body from the animal sources, the vegetable sources is very scarce. So thank you. Any questions?